It's the 25th of July, 2020, and I have this absolutely first-class paper, a case report, which has been published online in the circulation, which you may not be knowing is one of the leading journals in cardiology. I cannot hesitate in defining this case report as extremely important in a clinical sense. This report describes a 43-year-old woman. The paper is from Italy. This woman was looking after her husband, who was already suffering from COVID-19. She had no fever, she had no cough, she had no shortness of breath, but she had chest pain. When the chest pain worsened, she landed up in hospital. Her ECG showed what is called an inferior lateral myocardial infarction, an ST elevation myocardial infarction. The ST segments were elevated in leads 2, leads 3, and AVF, and V5 and V6. The echo showed an ejection fraction of about 20 to 25%. There was akinesia of the inferior and lateral segments of the left ventricle and global hyperkinesia. The troponins were raised massively, about 11,000 nanograms per mil. The patient was taken for an angiogram, which revealed normal coronary vessels. There was no hint or suggestion of any atherosclerosis. The patient was shifted to the intensive care, where she began to worsen. Her blood pressure dropped to 70 millimeters systolic. She had to be eventually intubated, put on a mechanical ventilator. The X-ray showed pulmonary edema. But despite giving steroids, she was given methylprednisolone at a dose of 17.2 milligrams per kg body weight and immunoglobulin at 1 gram per kg body weight. Despite heavy immunomodulation, the patient died after 46 hours of admission. It was presumed that the patient, because she had normal coronaries, probably had myocarditis by COVID-19, because by now they had the PCR test report, which was positive for the Chinese virus. The autopsy was done, and this was very revealing. The autopsy showed that the heart had no virus, it had no myocarditis, which was surprising. However, it did have huge amounts of thrombi in the micro-vasculature. That is the small vessels which are not seen on an angiogram. They were full of blood clots. And it was these blood clots which were causing, or which had caused the heart attack, the cardiogenic shock, and eventually death. Surprisingly, the virus was not seen anywhere else in the body except in the lungs. Some microthrombi were seen in the kidney and the spleen, but nowhere else. So the pathological diagnosis was, based on the histopathology, that the patient had had an acute myocardial infarction caused by microthrombi in the microvessels. There was no evidence of myocarditis. The hallmark of acute myocardial infarction is the presence of what is called band necrosis, acute band necrosis, which suggests that there has been a myocardial infarction in the previous 1 or 2 days, and of course the presence of some inflammatory cells. So this case report highlights the fact that there may be situations wherein a clinical diagnosis would be impossible to make in the setting of an infarction produced by microthrombi. The researchers cite an earlier study which was published some weeks back, which had about 18 cases of myocardial infarction, in which 55% of cases had normal coronary arteries, but a mortality as high as 90%. So now that makes sense that apart from the conventional heart attack, a person can, by COVID-19, have myocarditis, and also, as this report suggests, a heart attack because of thrombi, multiple thrombi in the microvasculature. Now, what is important to discuss here is the fact that how do we treat these patients? Now, this report says that the lungs, apart from the microthrombi, also had evidence of interleukin 6. Now, interleukin 6 is a what is called an inflammatory marker, which can only be tackled by anti-interleukin 6 medicines such as tocilizumab, right? Here, the steroids do not work in this patient. Maybe the response, the hyperimmune response was too much for the steroids to work. So now we have, and the researchers also point out that till now, the 67 hearts which have been autopsied, only 5 have shown myocarditis. Now, this could also mean that people who have myocarditis, that is viral infection directly or indirectly of the heart, the majority of them recover. As I mentioned in one of my previous videos, there were some young people, a 16-year-old boy, a 37-year-old man, and a 60-year-old man. All 3 had myocarditis confirmed by an MRI and all recovered. But when a person dies and only the heart is affected, myocarditis is rarely the cause. So how do we treat these people? As I've said, I think one goes straight for an angiogram. If the arteries are normal, then one can presume there is myocarditis. One should do rapidly an MRI if the facility is available. If there is no MRI, then I think one has to straight away go onto anticoagulants and to anti-inflammatory drugs. The point here is that this patient did receive high doses of steroids, and also, despite that, the patient still died. So that is a very important point to keep in mind. Now, apart from this cardiology case, I have to highlight another case report. This is not a case report. This is actually a study, a randomized study to boot. We have very few randomized studies on hydroxychloroquine. The temperature is so high where HCQ is considered that now we have, like we've had vaxxers and anti-vaxxers, we have large groups supporting HCQ and large groups which now are very skeptical about HCQ. So we have the pro-HCQ groups and the anti-HCQ groups. Now for the pro-HCQ groups, this study would be a disappointment. This is a randomized study which has come from Brazil, has been published just 2 or 3 days back in the New England Journal of Medicine. This has about almost 650 or 60 cases of COVID-19. These patients were divided into 3 groups. One group was provided supportive therapy, the usual treatment, which consists of antivirals and steroids and immunomodulation. The second group received, apart from standard therapy, they were given hydroxychloroquine at a dose of 400 milligrams twice a day. The third group received, apart from supportive therapy, hydroxychloroquine plus azithromycin. The researchers have shown that over a span of 2 weeks, there was no difference in clinical outcomes with hydroxychloroquine. Now, this study comes close on the heels of the recovery trial, which was a much larger trial, which was done in almost 3,500 people, which again showed that hydroxychloroquine provided no clinical benefit. There has been an earlier Chinese randomized study of 200 patients published in the BMJ, which again showed that hydroxychloroquine really did not work in patients with mild to moderate COVID-19. The Brazilian study is important. It is important because this study included only mild to moderate cases. And these are defined as patients who did not require oxygen, or if they did require oxygen, it was just supplemental oxygen to the tune of 4 liters per minute, so which is not a very high dose. So the argument which has been made, or the critique which has been made about the recovery trial regarding hydroxychloroquine, that in that study patients were taken too late, Now that doesn't apply in this study, because in this study, patients were mild to moderate clinically, plus these patients were given hydroxychloroquine as early as 7 days from symptom onset. So now we have another randomized trial establishing the non-clinical efficacy of, or the clinical non-efficacy of HCQ in COVID-19. This may be very disappointing for Donald Trump, who has been touting the role of HCQ for so many months. However, that's a different issue. I will not go into it. But the good news today is that yesterday in Delhi, only 1,025 new cases were picked up. Only 32 people have died, which clearly shows that the incidence of this disease is rapidly declining in Delhi, as also is the death rate. The only thing which can be considered to be the cause of the declining number of new cases and the declining deaths and the empty hospitals, the empty ICU bedded hospitals, the empty beds in ICUs, is the fact that most probably Delhi has hit herd immunity, as I mentioned in my last video. Now this hypothesis of mine is buttressed by the fact that we have now multiple studies. A very interesting article was written yesterday in the New York Times, which highlighted the fact that there are 2 studies which have shown recently that antibodies last for a month. This one is from King's College, England, London, and the other study is from Mount Sinai. The King's College study only has 65 or 67 patients, so that's a very small study. But the Mount Sinai one is very weighty because it has almost 20,000 people who were seropositive. That means they have 20,000 people who have developed antibodies, and they have used a test designed by their own laboratory, which has a specificity of 100% and a sensitivity of about 92 to 93%, which is a first-class ELISA test to detect antibodies. Now, they found that at least for 3 months, you had the presence of antibodies in people who had been infected by COVID-19. But the important thing to remember is what I have been highlighting for so many times now, is that apart from antibodies, the body also has white cells, which are called T cells. These T cells are manufactured in the bone marrow, they mature in the thymus, and therefore they are called T cells. These are killer cells. They go directly and attack the cells which have been infected by this virus. And more importantly, these T cells are also having what are called memory T cells. Now that's a group of cells which in a future infection will ramp up production of proteins to fight, of cells to fight against a future infection. Now there is a study from Singapore which has been published a few days back in Nature, I think less than a week ago. And this is an excellent study again. This is not a very big study, but they have 3 groups of people in this study. One group has suffered from SARS, has suffered from COVID-19. The second group has suffered from SARS, the disease which appeared 17 years ago. And the third group has not suffered either from COVID-19 or from SARS. The interesting fact is that the first group, that is the people who suffered from COVID-19, all of them developed T cells, right? Now that is very important. The second fact is that the second group, this is a group which had suffered from SARS 17 years ago. Even now, 17 years after the initial infection, after the index infection, they still carry T cells which can act against the SARS-1 virus. Plus, crucially, these T cells can also act against the Chinese or the Wuhan virus, which causes COVID-19. That's a very important fact. That means if these people who have been infected by SARS, now they have immunity against COVID-19. And they have been carrying these T cells for 17 years. So despite the fact that you have trials which have been published, which are stating that antibodies will last not more than 3 months, or at least for 3 months, we have data now that is concluding and which are convincingly showing that there are T cells which act against the Chinese virus, and also that these T cells can operate for as long as 17 years. Now, in the Singapore study, they had the third group. Now, this third group had neither suffered from SARS nor had it suffered from COVID-19. But importantly, a large chunk of them, in fact, the majority of them had T cells, probably which had developed following earlier common colds or coronaviruses, which were capable of tackling the Chinese or the Wuhan virus. So we have one paper already published in Nature. Apart from this, I think I mentioned in the last video about the paper from Tübingen University, that is Germany. This has studied about 360 people divided into two groups. The first group is of 180 people, 180 patients who have already suffered from COVID-19. Now, all of them developed T cells, regardless of the intensity of the infection, which means that even if they had mild COVID-19, they may have not produced a very high titer of antibodies, but they did have adequate number of T cells. That's the first group. The second group, again of 180 people who had never suffered from COVID-19, the German group has found that these people also have T cells, all right, which can tackle the Chinese virus or the Wuhan virus. Thanks a lot. Sorry. So the German study is again highlighting that despite the fact that a person may not have suffered from COVID-19, that person would be harboring or would be carrying T cells, which can, if it so happens, if they get infected by the Chinese virus, the T cells can protect them. Now, the T cells can operate in two ways. Either it can prevent an infection, or maybe even if the infection does occur, it can dilute the damaging effects of the virus. This is a very important thing. Apart from these two studies, the Singapore study and the German study, we have another study from Sweden, which again shows that a large number of people have T cells which can cross-react against the Chinese virus, which causes COVID-19. And this is from the Karolinska Institute of Stockholm. And then, of course, we have another big study from Sweden, which has shown that people who develop antibodies, twice that number of people develop T cells against the Chinese virus. Now, this probably is the reason why there is now a decline in the number of deaths, a decline in the hospitalizations of COVID-19 patients. The strongest reason is that people have either developed antibodies because they have been infected already by COVID-19, and also that a large chunk of the population, a large group of the population also has T cells which have been produced by previous common colds which were caused by the milder coronaviruses. Now, this could be the situation in just about every city, particularly in Delhi, because in Delhi we've always had some kind of viral infections going on throughout the year, and quite a few of them must have been because of coronaviruses, and that is the reason why we have a sharp decline now, despite the fact that we have only 23 to 24% of people having antibodies against the virus. We have a sharp decline in the number of cases and in the number of deaths. So I will leave you with this good news. Please remember that if anyone tells you, if you read it in a newspaper, if you watch this on television, or if you get a WhatsApp message telling you that antibodies may not be produced, and if they are produced, they may last for a very short time, maybe only for 1 or 3 months. That is not the truth. The antibodies may not last for at least 3 months. They could last for maybe a longer duration, but definitely the T cells will be present, and these T cells could easily go on for years and years and years. I don't understand why, if T cells can last for 17 years, following the SARS virus, which came about in 2003, why T cells against the Chinese virus will not last. All right. So thank you very much. Good night. And that's it. Thank you very much.